so that was a very long time ago, but I'm still in that field, and I'm currently an ICU and critical care outreach nurse working locally. And I happen also to be president of the International Society for Rapid Response Systems. You can see the title of the talk, and hopefully that will emerge as we go through it. So this is how many people died in or soon after hospital care in the last year, 300,000 deaths. So if you average it out by trust, that's over 2,000 deaths per trust. And obviously it depends a little bit on the size of the trust. And if you just look at the stats, what it says here is that there's a number of trusts in the bottom part of this diagram that have fewer than expected deaths, a whole bunch that have as expected deaths, and some that have rather more than expected deaths. And these data are supposedly case mix adjusted, although some people would debate that. But what I don't think any of us could argue is that we don't have probably at least some instances in our organisation, some deaths, which are potentially avoidable. And that's what I want to focus on to start with. So, and indeed, Liam Donaldson and Aradazi and colleagues, when they analysed a big patient safety database, national database, they reckoned that the biggest cause of avoidable death in hospital was due to failure to either recognise or to act on deterioration. And that's absolutely a finding that is echoed around the world. So it's a big issue, and I would argue maybe the biggest issue that we need to deal with in the hospital. Whether or not it's a priority in every hospital is a different question. So just thinking about one particular case, so sometimes I'm asked to review cases from my own hospital and other hospitals, and I won't tell you which hospital this is from, but a case that maybe brings up a few thoughts. So this is about a patient who presented to ED with a history of alcoholism, and even in the ED, the diagnosis was pretty obvious. Pancreatitis was the label given, and the patient was admitted. So he had a consultant review. This was in sort of the early hours of the morning, and was handed over to the incoming day team, and it actually said in the notes, he's fine, needs a bit of work, but he's fine, needs admission, but he's fine. And at 8 o'clock, the day FY1 was asked to look after this patient, and of course a whole load of other patients too, but was given responsibility for this particular patient. The patient was already known to be in significant pain and to be oliguric, and some fluids and some painkillers were given, which was pretty sensible, but actually there wasn't much improvement. The patient didn't feel much better. So the FY1 sought some help from a gastroenterologist, and the gastroenterologist said, why don't you examine the patient and review the history, which had, of course, already been done, but that was the advice given. And through the morning, the patient became tachypneic and tachycardic, urine output fell off a little bit more, pain was a bit worse. Clearly, all was not well. And this was on a busy medical ward in a major hospital. By around lunchtime, the patient was complaining that the catheter was hurting. So after a bit of discussion, it was removed. And the patient felt more comfortable, but obviously a bit of monitoring was lost as a result. Some bloods had already been done, and when they came back, they showed liver enzymes and creatinine to be raised, but those weren't escalated to senior staff. So there were some significant derangements of the blood profile, but those were not escalated. And by tea time, the patient has actually started to develop hypotension. Blood sugar was noted to be high. The patient was a bit cold and clammy. The FY1 came back again. I was really quite concerned about the patient and noted that the line that was in was sort of half hanging out. That's really the main means of treatment that was available at that time. And the FY1 sought help from an FY2 and then from anaesthesia to get a new line in because it was difficult, but both those people were busy. However, the FY1 came back again a couple of hours later, and by this point the patient wasn't in the bed, said to the other patients in the bay, where is this person? And they said, oh, he's gone out to toilet, felt a bit better, gone out to toilet. So, a little bit of a revival. The doctor went round to the toilet, banged on the door. There's no answer from the toilet. and the patient is dead on the floor. So who in this room thinks that this death was at least potentially avoidable? Okay, who doesn't think it's potentially avoidable? Okay, whose fault is it that the patient died? You tell me. The hospitals, okay. Well, the medical director in this particular case, in this particular hospital, said it was the FY1's fault, and probably they should be disciplined, and maybe worse. So it was part of my job to look into the circumstances of this case, and there were clear signs of multi-organ failure emerging through the day. I think we would all recognise that. But it's not that simple. The doc was a new doc who was already having panic attacks coming to work. As it happened, the nurse was new too. The nurse had 4 other patients in addition to this one on this very busy medical ward. 3 were geographically some distance away. 1 kept dropping their blood sugar. 1 was being prepared for theatre, and the nurse had been on duty since 7:30 and still not had a lunch break at 4 o'clock. The reg was also new, still learning, and as you saw, help was sought from senior staff, but was not forthcoming for various reasons. And the gastroenterologist looked a bit shamefaced when their part was explored at some meetings that we had. So I guess what I'm saying is that these cases can be complicated. If I'm going to make it simple, this is simple and simplistic, what we need to be sure of is that we have reliable, regular recording of vital signs and bloods and other signs, that significant abnormalities are recognised and then reported or escalated, that there is a response that fits the needs of the patient, and that we repeat that cycle until the issues are resolved, because even good treatment doesn't always do the job for sick patients. But that's quite simplistic. We'll come back to how simplistic it is. And I suppose we might start by saying that if nothing else, in or out of the hospital, we should have confidence in our early warning system, and we now have a national early warning system with a new edition coming out last year that I played a part in developing. And this little graph here, this little table here, is data from some Scottish emergency departments where they show quite clearly that measuring just 1 news at the front door of the hospital, just once, correlates very well as the scores go up with increasing risk of death over the next month. Now, if you look at the area under the receiver operating curve, 0.7, what that says is it's a fairly accurate tool, but not super accurate, and maybe you need to think about other things, and I would say that you do need to think about other things. So in my hospital at UCLH, of course we measure the standard vital signs that are at the top, but we're also trying to engineer that each and every time the observations are done, that there's an interaction with the patient, so we get some extra information. So the patient is asked, or should be asked, are they better, worse, about the same than last time the nurse came round? Now, of course, if the patient says they're worse, then that would beg the question, why? And it might be a medical problem, it might not be, but there might be something to be done. And then over and above that, let's think about the background to the patient. All the vital signs we've described, that's acute physiology. But where does that sit with the patient's chronic physiology? Is the patient frail and elderly, somewhat bedbound, somewhat limited? If so, they're less likely to be able to withstand acute deterioration than someone who's normally fit and healthy. And we need to tie those 2 things together more, and we don't do that enough. So this is what's on our chart. And indeed, the idea of patients playing a part in escalating their care when it's needed is a growing idea, and particular shout out for the people in Reading that have been doing this for a lot of years. This has only just come out. A nice analysis of calls from their patients. So they give patients a specific number to call, and they can call directly if they don't feel happy with what's happening on the ward, or their families can do that. And as I hope you can see, they don't get that many calls. 10,000 referrals a year. A very small number are from the patients or their relatives, so the system isn't abused. but the calls are of significance and they're highlighting clinical concerns or communication issues that are not coming through by other means. And it also provides the patients, I guess, with some feeling of security, some confidence in the system that they have that ability. This is well worth thinking about how you would do that in your own hospital. I would say, well, of course I would. I'm the guy standing at the back of that picture, that to do this properly, you probably need a dedicated team. Now, there are some perfectly good hospitals that manage deterioration very well without a dedicated team, but they're in the minority. The ones that do well, on the whole, have a dedicated team who are both engaged in the response, but also much wider thinking about the quality improvement that's needed to engineer patient safety across a hospital. Just going back, thinking about the deaths again, well, one of the questions you might want to ask is, how many patients can be saved? And it's worth remembering that about 30% of patients in any hospital are in the last year of their life. That's an important statistic. And if they're older, if they're 85 or more, about half of them are in the last year of their life. Do we appreciate age and frailty when we're making treatment decisions? Do we do that enough? So we would say that, well, you might have a sort of bundle of care for deteriorating patients in general that talks about having a treatment escalation plan early on, vital signs being done, escalation response and all the rest of it. But we need to go a bit further than that to think about those that may be irretrievable or might actually be harmed by aggressive care. And this is our international study, but a lot of UK hospitals, of critical care outreach responses to patients on wards. And you can see, I hope, that about a fifth of referrals from the wards end up in the patient going to ICU, but that means that nearly 80% will stay. Almost 10% are dead in a day, and 20% within 4 weeks. And 24% of the patients, 1 in 4, are getting care limits that are put on by the outreach team or are instigated by the outreach team in collaboration with the ward team. Now, the question is, why is it waited for the patient to be collapsed or semi-collapsed for that decision to be made? The patients have usually been in hospital for a number of days before this occurs. This might be a call in the middle of the night, not really the right sort of time and environment to be having a discussion with the patient and the family about what is most appropriate. So we need to move that upstream, although we know that's difficult. And I think this is really important. This is work from the team that developed the very first early warning scores and critical care outreach in Australia many, many years ago, but a recognition that elderly people need sometimes to be protected from aggressive care, elderly and frail people. And they've developed a sort of checklist to help you differentiate those that are likely to die from those that are not. And those kinds of principles have also been put into some electronic systems. This is an Irish system that I like. I've got no particular connection with it, but it pulls together various bits of acute and chronic data about the patient, gives you a variety of scores, and as you might be able to see, estimates a risk of death within a certain period. Now, this is a patient who isn't at high risk of death in the next 24 hours, but if we make the signs worse, patient's got an abnormal ECG, well, the score rises and a prompt comes up. Has there been an end-of-life discussion or treatment limitation instigated? It doesn't say you've got to do it, but it's a prompt to do it, and it provides the clinician with a sort of overall picture of the patient that might be helpful in their thinking. So what does good look like in this context? Well, so this is from our intranet from 2 weeks ago, and there's some of the outreach team here and some of the ward patients, and the reason that they got themselves onto the intranet is that the UCH Acute Medical Unit, which don't forget is the recipient of about 130,000 patients presenting to ED each year, has had no cardiac arrests for about 4 months. And the team leader of the outreach team, working with the ward team, has sort of brought out the key learning points. Leadership has been critical in both nursing and medicine. Better decision-making, better treatment escalation planning, DNR decisions, management of sepsis, probably the single biggest cause of deterioration, improved vital sign recording using news, and timely escalation to critical care. And I think most recently, real engagement with learning from the few cardiac arrests that we do have. One of the good things about there being few of them, that you can really concentrate on those few instances and learn some detail from them, and something about improving end-of-life conversations. Because even though we know patients are old and frail and may not benefit from aggressive treatment, having those conversations turns out to be really, really difficult. And when we polled our senior staff and consultants, many of them felt very uncomfortable with that and certainly didn't necessarily share either the religious or ethical values espoused by the trust. So part of our training is to try and explore that. So I would draw your attention to this or something similar that you might do yourself. Our outreach team has led the development of a one-day and indeed a shortened half-day course called Talking DNA CPR, bringing in these various people. The psychologists are there to help the clinicians think about their own thoughts and feelings, attitudes, values, beliefs about these issues, making sure that's informed by the law and by standard ethics, bring in palliative care and critical care, and patients themselves. And it's a slow process, but over time we've got more people thinking about and talking about these issues more often. And all this is showing is that there's a shift in confidence with having these discussions after people have completed the course. And this is for docs and nurses and AHPs and anybody else who wants to do it. Okay. I guess at the end we might get what your thoughts on these issues might be. Thank you.
Thank you. Thank you very much.